Can I have someone to help me with the laptop, please? Hello, everyone. Thank you for your very kind words. And I'm very happy to be here. It's a wonderful opportunity to be amongst the younger generation, because all of us actually are looking forward to take musculoskeletal ultrasound forwards, much forward than we had anticipated in these last 10 years. In the time that the laptop is being set, we're just going to bring a little small functionality. So it'll be great to know how many of us are doing musculoskeletal ultrasound actively amongst the audience. Are we doing ultrasounds, musculoskeletal? Okay, so is anybody ready to do it for the first time today? Because I would really appreciate if somebody would say that, yes, I want to be the first one to go for a hands-on. Fantastic. May I know your name? Excuse me? Amol. Right. So Dr. Amol will be, I am going to make my presentation a little short. We'll have a live demo, and then we'll invite you over to go on and see whether ultrasound is easy or not, so that you can spread it around in your friends, start doing it. Okay, great. We have 3 ultrasound cases, and we will be doing a live demo side by side. We are making a small change there so that we can have crisper pictures coming on the screen. In case it doesn't, we will probably bring everybody around and everyone can gather. We're a small group so that we can have a direct vision of the live demos. So I'm just going to go very briefly over the sonoanatomy of the knee joint. It is not a fight, as Dr. Gaurav and Dr. Karat has gone on to explain, that ultrasound today is not here to take away a space. Ultrasound is here as a complementary cross-sectional modality with MRI, with X-ray, with CT scan. It's just another step that has been added into a patient review, because I think each one of us, when started becoming a doctor, we actually in our own selves created a moral responsibility of delivering the best to the patient. Rest of the things became immaterial. We are here to deliver to the patient. And if ultrasound as a somewhere in the middle, now it's entirely up to you or to your physician where ultrasound would want to fit in. Whether they would want to do it before the X-ray. Why? Because radiation is bad, and we are trying to go green. We are not trying to grow green just in the environment. We are wanting to go green as far as the patient safety is also concerned. And we all know that radiation, bad. ALARA, good. So as low achievable possible. So whether we want to put it before the X-ray, after the X-ray, before the CT, after CT, but what has actually come to be established is that musculoskeletal ultrasound today as a modality should not be. I'm using the word should. Cannot be. Only you can make that possible. So we're just going to talk about MRI. We've already talked about MRI, so we're going to talk about ultrasound and why would we want to do ultrasound on a knee joint. Knee joint is one of the easiest joints. If at all each one of us wants to step into musculoskeletal ultrasound, start doing the knee joints, it's amazing, because the concept of anatomy, which is actually we run away from the first year onwards, believe me, comes crystal clear. For tendon injuries, meniscal pathologies. Now, we have a caveat there. Not all meniscal pathologies, like bucket handle tears, no. we really cannot give you an ultrasound diagnosis on a bucket handle tear, but there are indirect evidences which we'll be able to tell you so that you can go for a better modality. Whether you would want to go in for a CT or you would want to go in for an MRI, this is the modality which will give you a direction. Injuries to the ligament, it is a fantastic modality for the ligamentous injuries. And when we are talking about knee effusions, I think it was created for effusions. Ultrasound and fluid and effusions, wow, that is the modality where we need to go into. And of course, the muscle tears. There are certain things where ultrasound is still actually gaining ground. As the technology will keep becoming better and better, probably we'll be able to give you intra-articular pathologies, but not now. Bone edemas, yes, but not now. We're talking of subluxations, we're talking of bucket handle tears, we're talking of cruciate proximal segment tears. So in the cruciate, it has a very high negative predictive value. No, there is no tear. But when we're talking of positive predictive value, we're still looking at MRI and of course the labral tears. So what is the plane to begin? This is the plane. We start about 5 centimeters above the knee joint. Oh yes, we're starting 5 centimeters above the knee joint. In a short axis plane, we start from the thigh and go we translate our probe from the cranial end to the caudal end till we reach the knee joint, and the knee joint lines, as we say, on a medial and lateral side. So what do we see? We see here the cross section of the rectus femoris muscle, on the lateral side vastus lateralis, on the medial side vastus medialis, and this beautiful image of the vastus intermedius. Underneath you see the curvy linear acoustic margin of the short axis of femur. And this is of course here a panoramic view to show you how we can actually see the vastus medialis intermedius. And this is a tendon. So instead of 5 centimeters up here, we are somewhere just above the knee joint line. So we can see the entire rectus body getting transformed into a short tendon. And we see the vastus lateralis and again the acoustic margin of the femur. So now for all effective purposes, we are right over the knee joint. Once we are here, that's exactly how the anterior quadriceps or the anterior evaluation, we take that entire knee joint in a form of a cylinder. So we go from anterior to either medial, or you can go lateral, we go posterior and come back medial again. So it's like in a cylinder, you're evaluating the entire knee joint. So anteriorly, we start again just above. This is a cranial to the patella. So we're talking about a long axis. This is not, of course, how you hold the probe. This is only so that for a demonstration purpose that in a long axis perpendicular to the quadriceps, we see the tendon of the quadriceps, which is made of fibers of the 4 muscles that get converted into the tendon. We have the superficial most fibers of the rectus femoris, then the medial fibers of vastus intermedius, vastus lateralis and vastus medialis, and the deepest fibers of the vastus intermedius. So why do we need this? Why do we actually need to see all these fibers? Because at the end of the day, we need to give a report whether it's a complete or a partial tear. And a partial tear involving the superficial fibers of the rectus going down to the medialis, or involving part of the intermedius, because that's where the management surgical will step in. Now, when we are talking about the anterior scan, we cannot forget the suprapatellar bursa. The suprapatellar bursa is actually a bursa which is in direct continuity with the joint space. So it's absolutely an interesting feature which comes up when we are doing an ultrasound, that when we take the depth, we don't measure the length of the suprapatellar bursa to give you a volume of what is the normal fluid. We take the depth and we multiply it by 2. So this is like about 10 cc's of fluid here. A minimum amount of fluid is always seen in the suprapatellar bursa, which is a normal fluid of a joint cavity extending into the suprapatellar bursa. So when we come, of course, deeper planes are showing 2 fat planes. There is a superficial fat plane which is called as a suprapatellar fat, and the prefemoral fat. So an S-shape split of the suprapatellar bursa actually separates out the 2 fat planes and gives us the evidence of joint effusion. In the long axis, and then we come in the short axis, in the suprapatellar region. That's the patella there. So we are in the suprapatellar region. And in the suprapatellar region, this is a very important part of the scan of anterior knee joint, because in the short axis scan, you see the contour of the femur. Then we see the articular cartilage. Now, this articular cartilage is very important because not only in adults, the first thing that comes to our mind, of course, is the degenerative changes. So part of this cartilage gets roughened or we lose this cartilage. And of course, that is something everyone can know. But when we are talking in terms of children, this is the place where we see the osteochondral injuries. Now, osteochondral injuries, you will see a part of the loss of the cartilage, and then you will see a donor site from there. So not only there will be a fragment that you will be able to see with an effusion. Naturally, if there is an osteochondral injury, an effusion will accompany, and you will be able to see that beautiful small area of the cartilage sitting separately, and then there will be a donor site, a concavity, and you will be able to say that we are dealing with a pathology here. So it's important. It actually becomes easy. Why? Because children are afraid. CTs are a little scary. MRIs are even more scary for the parents. It gives you an easy diagnosis. And of course, this hypoechoic area that you see here is the rectus, is the quadriceps tendon, which is seen in the short axis. This was just a small video clip that I was showing where how from the musculotendinous junction, we actually translate the probe cranial to caudal, and we come and form the rectus tendon or the quadriceps tendon. That's the minimal fluid here till we reach the superior pole of the patella, and we say that that's the quadriceps tendon, very beautifully seen here. So why are we going 5 centimeters up? As is known, musculotendinous junctions should actually be evaluated. It's like x-rays. When we are taking for a fracture, one joint above, one joint below. This is actually a rule that we follow in musculoskeletal ultrasound. Do when you're evaluating a tendon, please do go to the musculotendinous junction and evaluate from there down below, so that you don't miss out those small tears, those small pathologies, and just not completely focus on the tendon or the insertions. From here, of course, we go to the horn or the menisci. So from the anterior knee joint, I have moved on to the medial knee joint. And the first thing over the joint line, a long axis. So the probe orientation, when we are taking in this image, is a long axis, and you see a triangular fibrocartilage, very well seen. And this is where, of course, you can see the tears over and above there. Medial collateral ligament, you can see very clearly, and of course the lateral edges of the tibial condyle and the femoral condyle. So you can see and you can appreciate how we can see the cortical margins in any small pathology. This is again second thing, that when we are doing a tendon, do look at the musculotendinous junction. The second thing is any pathology of a joint, you will definitely find something wrong with the underlying cortical bone. If there is an irregularity, if there is a cortical erosion, if there is an osseous overgrowth, please do not ignore this sign and go on to see for the soft tissues. It's exactly like Dr. Bipin was showing in the shoulder joint. Every time there will be an articular surface tear, there will be an irregularity of the cortex of the shoulder or the humeral head. So do not ignore that. So the smooth cortical margins are absolutely a must for you to evaluate if there is an irregularity there. Of course, this is where, so what I've done is that if you can appreciate here the diagrammatic representation, this is in a short axis. I've gone all the way from anterior to the posterior. So this is from the anterior, and if this is what I'm seeing in the anterior long axis scan, this is my posterior long axis scan, and what I see is here the insertion of the semimembranosus. This again is in the midsection, a short axis scan, and you can see very beautifully the meniscus, the triangular fibrocartilage. From the medial side, I am coming back again to the anterior infrapatellar scan. So we had a suprapatellar scan. Suprapatellar scan, you see the quadriceps tendon, you see for the suprapatellar effusion, and you see for the cortical margin in a short axis, you see for the cartilage, and you see for the entire smoothness of the trochlear region. Now in the infrapatellar region, we have the concept is we have a patellar tendon. So that patellar tendon can be actually viewed in one span of your probe. No, it cannot be, because this is a very long tendon. So we divide the assessment of patellar tendon into just a proximal end. That means from the patellar pole, we put our probe. The cranial end of the probe actually hinges onto the patellar pole, and the caudal end rests on somewhere in between. So we have a proximal patellar tendon evaluation and a distal patellar tendon evaluation. So we move our probe from the patellar probe down to the insertion of the ischial tuberosity, and that's how we see the patellar tendon. Now, this is not just one view that you should restrict yourself. This patellar tendon has an insertion which goes all the way from the lateral to the medial and the pole. So the long axis of our probe should actually translate all the way in a long axis from the medial to the lateral side, so that you can cover the entire extent of the patellar tendon. And so in the short axis that's the view or the probe orientation, and we again move from the medial to the lateral, or from the lateral to the medial, and from cranial to the caudal, or caudal to the cranial, to assess the entire proximal as well as the distal end of the patellar tendon. So this is the panoramic view for you to get an overview of what I have talked about till now. We have the quadriceps tendon, the entire quadriceps tendon from the musculotendinous junction going to the superior pole of the patella and going down over the patella, getting converted. Few of the fibers of the quadriceps tendon, I am sure that each one of us knows, go over the patella and merge with that of the patellar tendon. Few, that's most superficial fibers of the rectus femoris. So that is what is the continuity into the patellar tendon and going over to the insertion of the tuberosity of the tibia. So that's the Hoffa's pad here, and that is the suprapatellar recess that you see in between the suprapatellar fat pad and the prefemoral fat pad, and that minimal fluid is a normal one. Again, Hoffa's pad, fat pad for you. The significance is that when there is a tear or the inflammation, patellar tendinitis, you see vascularity in Hoffa's fat pad, and we should not ignore, because that becomes a part of the complaint. Also, when we are doing the arthroscopies, the probe, the instruments that they go through the Hoffa's fat pad and create an inflammatory response, and the patient can come back with chronic pain syndromes. Pre-patellar scan plane, and we will be just showing you one of the cases. This is a very important part of the evaluation, which is very popularly called as the housemaid's knee. Now, when we are talking of the housemaid's knee, it doesn't happen with only the housemates. If you are having a direct impact injury and your patella fractures, maybe not, but there is a pre-patellar bursa that is there in very superficial. So you need to take a good gel pad, gel standoff, so that we don't obliterate a very soft putting of your application of your probe in the region, and that is where the pre-patellar bursa stands. This is the caustic shadowing of the patella. Again, we have the quadriceps in the suprapatellar region and the patellar tendon in the intrapatellar region. This is again a panoramic view, and if there is a fluid or the bursitis or inflammation, then the pre-patellar bursa gets inflamed and there is effusion, which is translated into a black shadow with a very nice contrast, and you see a pre-patellar bursitis, again the patellar tendon, and you have a lot of edema of the soft tissues. Again, a same view of the pre-patellar bursitis sitting here, and of course there is an underlying crinkling of the patellar tendon, which indicates that there could be a pathology or a tear. As you can appreciate, the deeper parts of the tear and the fluid is going into the subcutaneous tissues. Again, an important pre-patellar region, and this is the probe orientation. You can do it in extension if the patient cannot flex because of the pain, and in any case you will be able to appreciate this. Now, there is a very controversial topic whether we can see the anterior or the posterior cruciates. Anterior cruciate, it's a divided consensus consensus that comes from US and Europe, and Europeans say yes, we can see, and the US says no, MRIs. Anyhow, what is a common consensus to which people have agreed is that in a proper positioning, which is extreme flexion degree of the knee joint in a particular position, if the probe is kept, then you can see the distal portion of the anterior cruciate. And again, as I had said, it has a very high negative predictive value. If there is no tear or strain, you can actually say closed. There is no anterior cruciate involvement. However, if there is a strain, grade 1 tear, grade 2 tear, there will always be a problem to give a confident report on an ultrasound, and we need to see, but there are indirect signs. The indirect signs are, like you can see here, that this is a normal anterior cruciate that you can see, and the indirect signs, usually there is a hematoma that forms around, or there is an avulsion chip that comes from the tibial attachment, and you can see that as an echogenic lesion within the cavity, and it will be translated into that we need an MRI on this patient. Going back to the medial joint space, we have medial collateral ligament that starts from the adductor tubercle all the way down and attaches itself to the anterior tibia, medial tibial condyle. The importance of this is that it forms a complex medial collateral ligament underneath the fibrocartilage, which we call the meniscus, and the anterior cruciate. They form a compact complex. So a tear or a strain of the medial collateral ligament, start looking for something in the medial meniscus, or go on for an MRI for a cruciate injury as clinically may be directed. That's again a panoramic view of the medial collateral ligament that you can see here, the probe orientation for you in order to see from the adductor tubercle going down to the insertion of the tibia. On the medial side, a very important a part of the evaluation is pes anserine bursa. So pes anserine complex is formed by the 3 tendons of the sartorius, gracilis, and semitendinosus. These 3 tendons are the hamstrings. They start from the ischial tuberosity, travel all the way down, cross over to the medial side to take the insertion in the anterior portion, proximal tibia. Pes anserine has got importance because of the bursitis that it lands up into, and these 3 tendons cannot be separated at the point of insertion right here. But yes, we can have an indication, and they can be seen as 3 separate segments in the proximal medial knee joint, which we'll go on to show you. That's exactly how the bursal attachments may be, and in a long axis scan here, this is how you see the 3 tendons in the proximal portion, but where the attachments are going to be there, it's just small blobs that you see sitting just beneath the inferior genicular artery. This is just how you see at the level of attachments the 3 blobs of the pes anserine complex, and this is of course the medial genicular artery that pulsates and separates it from the attachment of the medial collateral ligament. So we've already talked about pes anserine. Medial patellar retinaculum. Now these are retinacula. These are very small fibrous sheets which attach the patella and merge along with the tibia on both the sides. They actually merge with the iliotibial band on the lateral side as well. What is the importance? The importance is that despite being small, thin fibrous sheets, they hold the patella in place, and on the medial side there is a very tenacious ligament that runs through. These are usually bilamellar or bilayered structures, but on the medial side it's a trilayered because in between runs the MPFL. I'm very sure that one of these days your orthopedic surgeon is going to come back and say, is there a tear of MPFL? And MPFL is the mediopatellar femoral ligament. It's a very tenacious, thin ligament, but it runs in the medial retinaculum, and it's one of the stabilizers of the patella. So the subluxed patella, when there is a tear landing into degenerative changes, is important evaluation. What you see here is, of course, the femoral condyle, and that's the patella. And on a short axis scan, that's the probe orientation for you. You see a trilamellar echogenic structure that's running from the femoral condyle onto the patellar surface, giving you the medial patellofemoral ligament, an important evaluation of the medial of the knee joint. That's of course the lateral joint for you. You see the patella. That's the position in which we scan our lateral knee. The long axis right here of that you see will be the probe orientation here, will be for the iliotibial band. We have just 4 structures on the lateral side that we really want to see. The most important, of course, is the iliotibial band. The second is the lateral collateral ligament. The third is, of course, the lateral meniscus. And the fourth is the insertion of the biceps tendon, long head of the biceps femoris that inserts on the fibular head. So these are the orientations that we will go on to tell you. This long axis is for the iliotibial band. This long axis is for your lateral collateral ligament. And of course, this is the lateral joint line to give you the evaluation for the meniscus. And in the same one where we are talking about the iliotibial band, if we orient it a little posteriorly and go on to our fibular head, we'll be able to see the biceps femoris. So just quickly run over lateral collateral ligament, long axis scan underneath the fibrocartilage, not very clearly seen. However, gives you an important directive that if you see the meniscus, then we are really talking about the lateral collateral ligament. Lateral collateral ligament, which takes its insertion on the head of the fibula here. It starts from again the femoral condyle and runs transversely longitudinally to the fibular head. Lateral meniscus, again, there is an anisotropy here. Otherwise, it should be seen exactly like we see the echogenic medial meniscus. There is a little bit of anisotropy. The anisotropy has been obliterated here. You can see, I'm sure we all know what anisotropy is. Anisotropy is when we change the orientation in a craniocaudal manner, and the echo pattern of the tendon changes from black to white or white to black again. So that anisotropy is because our angle of insonation is not perpendicular to the structure that we are evaluating. So we remove the anisotropy here, and we can again back see the lateral meniscus as a triangular echogenic fibrocartilage. So again, we are seeing the same thing in the lateral collateral ligament in a panoramic view, the lateral collateral ligament again, and the meniscus for you. And from the iliotibial band is a fibrous structure that actually runs from the upper thigh all the way laterally along the thigh, just over the superficial to the vastus lateralis, goes down and gets inserted onto the Gerdy's tubercle, which is a small bump that you see in the proximal tibial condyle, lateral tibial condyle. And this is how the lateral iliotibial band is seen and takes its insertion, a broad insertion on the Gerdy's tubercle. It's a bump that you see. You can feel that bump on the proximal end of the tibial condyle. This is again a panoramic view. You can see the iliotibial band, you can see the femoral condyle. And why is this a lateral femoral condyle? Because you can see that popliteus tendon here going over to take its insertion down below on the Gerdy's tubercle. That's the tibial condyle for you. So lateral insertion of the biceps femoris, if you go a little posterior from the iliotibial band, this is the femoral head. Again, a long axis and a panoramic view where the biceps femoris comes and takes its insertion. So if you can see, we are losing the lateral meniscus somewhere. And what we see is here bump of the fibular head where the biceps femoris tendon inserts. Peroneal nerve is part of the evaluation we will be doing. You can do in a lateral evaluation, or you can go posteriorly to see for peroneal nerve. It's one of the branches or offshoots, common peroneal nerve from the sciatic. So at the level where the gastrocnemi are meeting, the sciatic nerve divides into tibial nerve and common peroneal nerve. And it's important because any trauma or any injury to the head of the fibula leads to a foot drop, and that's where you will need to evaluate the common peroneal nerve. Posterior knee evaluation should be the easiest part of the entire knee joint. We put a long axis scan and we see for the tibial nerve, this is like from the most superficial, which is the most posterior, to anterior, and we see the artery the vein, and the most superficial, where the common peroneal and the tibial nerve divide. You have the tendons of the semitendinosus, semimembranosus. Semitendinosus, you see the tendon, and semimembranosus, you see part of the muscle, tendon, long tendon, and semimembranosus is the muscle, and of course laterally you see the biceps femoris muscle, and this is again the same, where it is like a little cranial to where we've seen the it is a little caudal to where we've seen the common peroneal and the common peroneal laterally and the tibial nerve medially, and that's again the tibial nerve, the popliteal vein and the popliteal artery in the long axis scan, in the short axis scan of the popliteal fossa. The posterior horns of menisci are important evaluations when we are dealing with suspect tear of the posterior cruciate. So it's important that we should be able to see posterior. So again, this is a overview or diagrammatic representation. We go from the anterior all the way to the posterior end, and we can see the posterior cruciates also very clearly on an ultrasound. It's just a matter of making a choice between going separately in a posterior scan, or when you're doing a meniscal evaluation from the line of the joint line, you just go and circumvent the entire area to see the entire meniscus in one go. Semimembranosus, a Becker's cyst, an important but magical diagnosis in between the heads of the medial head of the gastrocnemius and the semimembranosus. And that's when you see a bursal cyst. It's also called as a popliteal fossa cyst. It has a beaking, a superficial and a deeper component. Here what you're seeing is just a superficial component. There is usually a deeper component also to a Baker's cyst. But popliteal fossa cyst can have components like sometimes can be hemorrhagic, and it's a one probe 2 seconds diagnosis. Posterior cruciate again, as I said, you see the distal portion of the cruciates, not the proximal end, and we can see the posterior cruciate in a long axis scan. If we put in a long axis our probe, you can see the posterior cruciate very much like you see the part of the anterior cruciate, and this has got a great positive predictive value again. Bursae around the knee joint, there are multiple. We've already spoken about the suprapatellar bursa, semimembranosus, semitendinosus bursa, or the Baker's cyst, and we are talking about the Pessant-Serine bursas, we are talking of prepatellar bursa, we are talking of deep infrapatellar bursa, and we will be seeing that all on the long axis scan. This is again a scan of a pediatric in a pediatric age group. Most important is that the patella that you see as just one echogenic line, you see that entire unossified patella in an oval form, hypoechoic form. Very important, because we've had, I never thought how many, but hypoplastic patellar syndromes really do come, and it's very important that we give a diagnosis that's a hypoplastic patella or it's an absent patella, if it's a subluxed or a dislocated patella in a child, and you can see the patella very clearly. That is an unossified distal end of the femoral condyle. So you see the distal femoral condyle, that part is the metaphyseal diaphyseal region, that's the epiphysis. This is an unossified patella that you can see, and in a long axis scan you can again see the growth plate. You can see now the ossific nucleus has come, another ossific nucleus of the tibia, and you can see the patellar ligament. This is an occult fracture that was there of a child of the distal metaphyseal region of the femur, which was kind of missed on an x-ray. Shouldn't have been, but it got missed, I'm sure. So this brings me to the end of my presentation. Thank you very much. So, you ready? Okay, why don't you join me? Come. We'll start doing the ultrasound. We'll do a normal scan of the knee joint. I hope that do we have hand mics? I would like, if there is any question that pops up in your mind at the time that we're doing the scan, do stop me, because it's now or never. If it can be, if I can sort out that question of yours there and then, otherwise it may skip your mind, and then we may not have the time to go back to it again. So can we just circulate the mics to anyone? So you're free to ask me, please stop me, and we will take it wherever it goes. Thank you. Okay, come, anyone else? एक बार आओगे? Do we have a... बेटा तुम आओगे एक बार? Come. Come. Give him a big hand, everyone. सीधा आ जाओ, सीधा लेटो, शाबाश. थोड़ा सा अपने इसको, what will you do? Perfect, perfect. इसको सीधा करो, इसको सीधा कर लो, शाबाश. There's a small bolster. We've rolled it up like this, and we're going to keep it so that the child becomes a little more comfortable. Yeah. So I'm going to be wingman for him. He is starting like we started, 5 centimeters above the knee joint. Sir, could you just be the wingman? Thank you. We're starting, and as you can see, that it's a thin rectus. He's a small baby, so he can, in order to confirm, he can go further cranially. Perfect, 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 and that's where the tendon is still not forming. So you can keep going up. Yeah, keep going up. Now. That's lovely. नीचे आएगा. So what you're doing is, let's see where your probe is. You actually needed to go a little more in order to know where your rectus is. Okay, so that is your, see where your medial, right here. He's a little child. Okay, so that's your vastus medialis. So, and vastus intermedius, and vastus lateralis. So what is this? What is this? See? That is the rectus. And you were pressing it so hard that it looked as if it was coming from vastus medialis. But that's your rectus. Okay? So that's your rectus and medialis and lateralis. So where you were going wrong was first of the position and lot of compression. You're compressing so hard. So go on, hold again, very lightly. Wonderful. Yes. And lot of gel.
Hold the probe.
आप probe को भी इधर से पकड़ो, correct, नीचे से पकड़ो और एक finger नीचे रखो. Hold it now from here. हाँ, that's it. Good. Now you got your rectus? Good. So we're having rectus and vastus intermedius and vastus lateralis, and you go on the other side, vastus medialis, femur, right? Yeah. Keep going distally. Perfect, perfect. So that's where the tendon is getting formed. Perfect, perfect. Make it into a long axis. Super. Go further distally till you hit the patellar pole. Wonderful, lovely. So that's the entire quadriceps tendon, suprapatellar fat, prefemoral fat, patella. Like it?
Yes.
Great. Now we go infrapatellar. He's doing a better job of me. Lovely. Not in a short axis, always on a long axis. First get your landmarks ready. Wonderful. Not too hard. We just make the depth. Very nice. So the infrapatellar, the pole of the patella, patellar tendon. Not too hard, very softly. Not too hard. So what do you see here? What is this that you're seeing?
Tuberosity.
He's a small boy, so it has not still ossified. Right. Great. Are we good? Medial. Let's go medial joint line. Very nice. Could you flex the knee? Yes. Long axis. That's too far behind. That's where you should be. Very nice. So medial cruciate, medial, I am in love. Medial meniscus, and that of course is the femoral condyle, tibial condyle, and a lovely medial collateral ligament. And that part is where the gel is deficient. Right. That's it. So now you have enough gel, you're having a beautiful image, medial collateral ligament, medial meniscus, ossific nucleus of the tibia, already fused, nearly fused ossific nucleus of the epiphysis and the metaphyseal region of the, थोड़ा ऊपर जाइएगा? नहीं, that is the ossific nucleus. The epiphysis has still not fused. That's the growth cartilage here, the epiphyseal cartilage, metaphyseal region, femoral condyle, epiphysis of the tibia, metaphysis of the tibia, the growth, very beautiful medial collateral ligament, very nice medial collateral ligament. Wonderful. On the other side, and that's the lateral knee scan. So we are still, yes, optimize the image. Right. Okay, are we good here? ये अगर आप ढीला छोड़ेंगे तो very good. So very right. इसको इधर रखिएगा. Just stop it here. नहीं, आप उसको छोड़ रहे हो. Right. So lateral meniscus, again the epiphysis, lateral collateral ligament, right there. Yes, lateral collateral ligament, and as you go anteriorly, okay, that is the anterior horn of the lateral meniscus. यहाँ पर फिर इधर आप पीछे जाएंगे तो ये इधर, this is a normal cleft that you see. That's a normal thing. फिर आप पीछे जाएंगे, you can see that, right? Further back, lateral collateral ligament, okay? As you go down, posteriorly, इधर से आइए पकड़िए इसको. So what you see is the wonderful. What you see is the iliotibial band, vastus lateralis. आप follow करो अपना iliotibial band distally. Not too much pressure. You will lose your iliotibial band. Yeah. It's a very superficial structure. Okay, right? Iliotibial band. Keep following it distally. Keep following distally. Keep following distally. Wonderful. So that's where you see the insertion. That's where you see the insertion, right here. Okay? Thank you. Thank you very much.
Shall we break for the lunch and then we'll start with the MR?
Okay. Whatever. Let's break for lunch.
Ma'am, that was an amazing presentation and an even wonderful live demonstration. Definitely some of us have learned musculoskeletal in a better way.